It's okay, I got warranty. I might as well use it if I had bought the warranty.
Okay, so that's better, if you can see it clearly?
Yes. Can I
Okay.
turn off the light?
Sure.
Both of them? Just one.
It's okay?
This one.
We can do both.
I'll fall asleep with this both.
Make sure you don't sleep, huh?
I promise.
Okay. So the topic today for discussion is about diabetes mellitus. And this metabolic disorder involving the pancreas is affecting a lot of people. So most people affected includes the African American. We have the Latinos, because you see the diet of many Latinos includes a lot of carbohydrates. And then also we have the Asian Americans. Like me, I have diabetes. I have type 2 diabetes. Okay, so most people think that if you are a diabetic, you are supposed to be obese. Not all people who have diabetes are obese, okay? So the problem with diabetes is if the individual cannot control, or shall we say, the blood glucose level, the common problem is the complications. Many people with diabetes die from renal failure, and also they suffer from retinopathy, which cause problem with vision, okay? So because other than respiratory conditions, other conditions are referred to as metabolic disorders. So from this presentation, if you see a question about acid-base balance, a patient with diabetes mellitus will develop metabolic acid-base disturbance. So in diabetes, our problem is the endocrine part of the pancreas. The problem is insulin production. Now the pancreas, as an endocrine system, produces hormones, important hormones that includes insulin and glucagon. The hormones are produced by the islets of Langerhans. So you have two important hormones. Okay, one is produced by the beta cells, and the other one is produced by the alpha cells. So beta cells produces insulin, and the alpha cells produces what? Glucagon. So the balance of these two is important to maintain a normal blood glucose level. Okay? So, however, there are conditions that results to diabetes because the islets of Langerhans, especially the beta islets, are destroyed by autoantibodies. So when the body's immune system destroys the insulin-producing islets of Langerhans in the pancreas, the production of insulin will become nil. So little or no insulin is produced in here. This is usually seen in people with type 1 diabetes, okay? And also there are those with insulin produced by the pancreas. However, the problem is the cells and tissues in the body develop resistance to insulin, although there are insulin produced by the pancreas. And usually this resistance to insulin produced by the pancreas is very common among people who are obese, okay? And usually this is late onset diabetes, and we call this type of diabetes as type 2 diabetes, okay? So we now know what is the cause in type 1. In type 1, there is no insulin produced, absolutely no insulin. That is why people with type 1 diabetes, if they need insulin, they have to have insulin injection for life. Otherwise, they're not going to survive. For type 2, they usually may be given something to stimulate the pancreas to produce insulin. So they're called type 2 diabetes. So before, we used this word, IDDM and NIDDM. But nowadays, we notice that not only people with type 1 diabetes use insulin. Type 2 people with type 2 diabetes, they also use insulin. in case the blood glucose is very difficult to control. That is why they changed NIDDM and IDDM to type 1 and type 2 diabetes. All right. So for people with type 2 diabetes, usually the onset of diabetes is later in life, like for example 45 and 60, that is type 2 diabetes. But for type 1 diabetes, the onset is usually during what? Childhood. Okay, so that is why they call that juvenile diabetes. That is the other term that they use for type 1. Because they are young, it's called juvenile diabetes. For type 2, they call that late onset diabetes. Or they call that the moody. Maturity onset diabetes of the young, because it could start at age 40. This is the acronym moody. I said maturity onset diabetes of the young. And then this one is called juvenile diabetes. Okay? All right, so in diabetes mellitus, the problem we said is either no insulin produced or there is insulin resistance. All right, now according to many studies, because they did a lot of study about diabetes mellitus, with the hope of finding cure for diabetes. I would be very happy if I could see that cure for what? For diabetes, because right now, you know, the level of stress affects diabetes. So every time you take medications, you think about your kidneys, isn't it? The more medications you get, the more concern you have for your kidneys and the liver. All right. Now, according to studies, they said that many people with diabetes, especially type 2 diabetes, they said this could be a result of what we call a metabolic syndrome. And the metabolic syndrome in diabetes that they are referring to includes this one, central obesity. So when I say central obesity, most people with diabetes, they have big tummies, okay? The abdomen could be big, but they usually have smaller what? Extremities because of protein, altered protein metabolism. Okay, we will talk about that so we will understand it better after this one. There is also another component, high blood pressure. Triglyceride level is high, low density lipoprotein is high. They should be low because it says low density lipoprotein, but they are elevated. And they also have low high density lipoprotein. So this one, that one, and this one are usually associated with hyperlipidemia. So high levels of what? Lipids plus low levels of high density lipoproteins, okay? So blood glucose level is usually what? Elevated. Now the normal blood glucose level has different normal range depending on which laboratory is done. Some laboratory says 70 to 110, some says 60 to 119, okay? But most doctors, they don't want you to reach the maximum. If you reach the maximum of 110 to 126, they already call you a pre-diabetic, especially if you have a diabetic history in the family. Now let us take a look at this one. Central obesity. Why is it that most of them, they have big tummy, they usually have smaller extremities? Because in diabetes, we don't only talk about carbohydrate metabolism, but we talk about metabolism of carbohydrates, proteins, and fats, okay? Now normally, in order, the end product, by the way, of carbohydrate metabolism is what? Glucose, right? So in order for glucose to be used as energy, because anyway, this is how glucose should function, they're supposed to be used as what? Energy. So in order for glucose to be used as energy, source of energy by cells, tissues, or muscles in the body, they have to be what? They have to be transported. They need something to transport them to cells and tissues in order for them to be used as source of energy. And what is that? That transports glucose to cells and tissues? Insulin. Okay? So what happens if there is nothing like in type 1, that would transport glucose to cells and tissues. Where does glucose pools or collect? They collect in the bloodstream. So therefore, the patient will have a high blood glucose level. Okay. And then we talk about high blood pressure. Hyperlipidemia could lead to early development of atherosclerosis and arteriosclerosis. Okay. Now this has something to do with vessel compliance. So when you say vessel compliance, normally when the cardiac output is increased, remember from cardio, the vessel should what? Dilate. But when the blood flow or cardiac output is decreased, the vessel should constrict. All right. So when you have vessel compliance, it's either that there are plaque which are deposited within the lumen of the vessel. That is the atheroma caused by atherosclerosis. Or the vessel becomes stiff as a result of calcium deposits, that is arteriosclerosis. So the overall net or bottom line is that if the patient has even an adequate cardiac output only because of decreased vessel diameter, that could lead to hypertension. Okay? And this hyperlipidemia causing hypertension could also make the patient risk for what? Coronary artery disease, that is one, and cerebrovascular accident, plus the hypertension. Hypertension, decreased vessel compliance, usually affects the kidneys and the heart, okay? So there is a problem in there. And then also low density lipoprotein level when decreased could give you risk for coronary artery disease. Remember that, yes?
Can they get MI?
Yeah, they can get MI.
Coronary artery.
Remember the coronary artery disease lecture in women? We said women are less risk initially for coronary artery disease when you are still in the productive years, because during the productive years, estrogen secreted by the female gonads help maintain a high level of high-density lipoprotein. But when you menopause, your risk for coronary artery disease is equal already to what? Men, because the estrogen level goes down. Okay? So I think we understand this part. And we know already that we will be alarmed for possible complications like this. So that is why the best management for diabetes is to what? Control the blood glucose level. And for people who have diabetes, they are supposed to be active, okay? And talking about activity, I would like to add in here that according to studies, people with diabetes, especially type 2, they identified that these people have decreased numbers of transmembrane glucose receptors, okay? Oh no, transporters, I mean. Now this helps transport glucose to cells and tissues. So if you have less numbers of this, glucose would pool in the bloodstream, creating a condition known as hyperglycemia, an increase in the level of blood glucose. So more than 110, but should be, they said should not be more than 126 milligrams per deciliter. Any question? All right. Now, the types of diabetes that we have discussed, there is type 1 and type 2 diabetes. So we already have an idea about type 1 diabetes. This is considered autoimmune. So therefore, the immune system destroys the beta islets of Langerhans, resulting to no insulin production. So therefore, the blood glucose in the body just pools in the bloodstream. All right. So insulin not transported. So when insulin is not transported, we have a problem with glucose metabolism, correct? So increase glucose because glucose is not transported. So what happens when there is no glucose transported to cells and tissues? As I have mentioned earlier, this is also affected. All right, let me get this clear. When glucose from carbohydrates is not transported to cells and tissues because there is no insulin available, glucose pools in the bloodstream, creating a condition known as hyperglycemia. Now, when the patient or when the body cannot utilize glucose for energy, the body would turn to proteins and fats to be converted as sources of energy. That is what they call gluconeogenesis. Okay? So when you say neo, it means say new sources of what? Energy. So gluconeogenesis. But the problem is, breakdown of fat will give you what? Fatty acid. Fatty acid could further be broken down into lactic acid. Lactic acid will give rise to formation of ketoacidosis. You get that? That is with fats. So the more fat converted into energy or utilized by the body, the higher will be the level of what? Ketoacids. And this is the reason why patients with type 1 diabetes are risk to developing diabetic ketoacidosis. Because there is no insulin produced by the beta islets of Langerhans. Are you following me so far? Okay. So they need what? They would need insulin injections. Okay? If you go to PEDS nursing, we always tell the students that at age 7 or after age 7, the child should already know how to inject his or her own insulin. So it is better that they become independent so that they could live like a normal individual. Okay? So we know what is this? Can you tell me again what I discussed about this? In type 1 diabetes? What did I say, Dennis? About type 1 diabetes? This one's?
Carbohydrates contains glucose, which can elevate the blood sugar. Also, breakdown of protein.
All right. So I said, in case of type 1, especially type 1 diabetes, because I initially said that the one that transports glucose, which is an end product of carbohydrate metabolism, to cells and tissues to be utilized as energy is what? Insulin. Now, in the absence of insulin, glucose pools in the bloodstream, causing a condition known as what? Hyperglycemia. So the patient usually will always feel hungry, will always feel what? Shaky. That is why the first P in diabetes mellitus is what? Polyphagia. Increase what? Eating. You eat and eat because there is no available energy for muscles and tissues in the body. Now, in order for the body to have sources of energy, the body would turn, because they cannot use glucose, the body would turn to proteins and fats. So this gluconeogenesis, to provide the body with energy, especially fat metabolism. Catabolism or breakdown of fat will give you this, right? To the point of increasing ketones in the body, a condition known as ketonuria. So patients with type 1 diabetes, I said, are risk for diabetic ketoacidosis. Now take a look at that protein. What is the use of proteins in the body? Proteins are needed to build up worn out tissues. If your diet is lacking in protein, you don't build muscles. That is why people who wanted big body, other than anabolic steroid, they use protein shake in order to build what? Muscles in the body. Now, if protein reserve in the body declines because of this gluconeogenesis, what happened? The patient, in spite of big tummy, they usually have smaller lower and upper extremities. Typical picture of what? What is that? Metabolic what? Syndrome in diabetes mellitus, known as central obesity. Okay? So people with type 1 diabetes, therefore, will use only what? External sources of insulin. Okay. Although they could be given other oral hypoglycemics, which we'll be discussing later. How many percent of the total population of diabetics are type 1 diabetic? 5 to 10%. So they're only small in the population. And most of them are children. And usually they could either be thin or they could be normal in weight. All right. So what about type 2 diabetes? When we say type 2 diabetes, this usually is the adult type of diabetes, or this called the late onset of diabetes. So it could start as early as 40 or may be discovered at age 55. All right. What is the difference between type 1 and type 2? Type 1, no insulin production, right? Type 2, there is still insulin produced by the pancreas. However, we said the body is resistant to insulin. All right. Now, type 2 diabetes could also be seen in children who are considered obese. All right. Now, in type 2 diabetes, we said there is still insulin produced. So, usually the body may still use the what? The insulin in order to transport glucose to cells and tissues, but it is not considered what? Enough. So they need something to stimulate the pancreas to produce more insulin. Now, every time I do lecture on diabetes, I'm also concerned because when you give oral hypoglycemics, we said this could, one of the oral hypoglycemic effect is to stimulate the pancreas to produce what? Insulin, like the sulfonylureas, stimulate the pancreas. But what is the big problem about continuous stimulation of the pancreas? The pancreas may not later produce what? Insulin. Because they undergo a process known as pancreatic burnout. So type 2 diabetic patient may also be using what? Insulin. Okay? So that's why I said every time I discuss about this, I'm so concerned about pancreatic failure later because of so much stimulation of the pancreas. Okay? Now, type 2 diabetics are usually what? Obese. So if 5 to 10% are type 1, therefore, where have you been? Huh? What did you say, Cindy?
Parking. We're parking.
But this is already 10, 15. I said 10 to 10. You know, I don't like people coming to my class that is late. Because, you know, my presentation I prepared already. Then all of a sudden I stop because I see people coming in late. My line of thought is already disturbed. I feel upset. If you're the teacher, how would you feel if people come to your class at their convenient time? How would you feel? You feel insulted, as if people do not respect you. I don't want that to happen again. In case it happens again, if in case I handle your class in term 4, you will be the one to discuss among yourselves because I'm walking out of the classroom. So I was saying that if 5 to 10% of the total diabetic population are children, then it goes to say that much of the diabetic populations are what? Type 2 diabetics. So it would be about 90% of the diabetic population will be type 2 in terms of diabetes. Okay? Now the major clinical manifestation or laboratory result that you would see in people with diabetes is hyperglycemia. But remember that hyperglycemia does not only talk about a diagnosis of diabetes mellitus. Now I have seen your book. There is a box there below that talks about other possible causes of what? Hyperglycemia. So if the other causes of hyperglycemia is not related to a diagnosis of diabetes, once they are managed, the blood glucose level will return to what? Will return to normal. Like for example, you have discussed in the previous chapters of the endocrine disorder about Cushing's disease. High levels of what? Corticosteroids or cortisol could give rise to increase in the blood glucose level. Okay? Inflammation of the pancreas, that is called pancreatitis. Remember the pancreas functions as both endocrine and an exocrine gland. So recurrent pancreatitis could later lead to the development of type 2 diabetes. And there are also medications like what? Diuretics. The thiazide diuretics could also give rise to an increase in the blood glucose level. And there are also people that every time they get pregnant, they develop hyperglycemia. So we call that gestational diabetes. These people with gestational diabetes, if that happens every time they become pregnant, later they may develop type 2 diabetes. Okay?
Is there a way to prevent that?
The fetus is the cause of the increased level of diabetes. So when you go to maternity, you will learn that when you become pregnant, your level of estrogen and progesterone increases above the normal level to maintain the pregnancy state. So this estrogen and progesterone acts as antagonists to insulin. That is why the blood glucose level goes up. But birth of the fetus makes the blood glucose level go down to normal. Okay? That is why it's called gestational, because the cause of the hyperglycemia is the pregnancy. Okay? So that is type 2 diabetes, I said, for people with frequent gestational diabetes. And then another thing that I would like to add is that if type 1 is autoimmune, type 2 is usually considered hereditary in nature. So this is why if you have type 2 diabetes, a question that they could ask you is that, is there any member in the family who is also having problem with an elevated blood glucose level? So that is hereditary.
So only type 2 is hereditary?
Yes, type 1 is autoimmune, all right? So what did I say about those medications causing diabetes, pregnancy causing diabetes? Are these people really diabetic? No, because once these problems that induces a high blood glucose level is addressed, the patient's blood glucose will return to normal, okay? All right, so you have discussed this, Cushing's, right? All right, so high levels of glucocorticoid that would increase the blood glucose level. All right, so this is what we have been talking about. And what was not discussed is levodopa. What is that levodopa? Oh, that will be for term 4. This one is used in the management of patients with Parkinson's disease. Okay, that is lorodopa or levodopa. And then oral contraceptives may also cause an increase in the blood glucose level. And TPN has a very high glucose content. That is why people who are receiving TPN with a family history of diabetes, they usually are ordered sliding scale coverage for insulin if they are taking total parenteral nutrition for problem with altered nutrition, less than body requirements. So that's what I said. When this cause are removed or addressed, the patient's blood glucose level usually goes back to normal. Okay? So So there are also people who are believed to be called pre-diabetics. So when you say pre-diabetics, what are these criteria for saying that an individual is a pre-diabetic? They have impaired fasting glucose level, or they could have what? Impaired glucose tolerance. These are people who are believed to be having what? Pre-diabetic or diabetes state. So when you say impaired fasting glucose, what does that mean? That the patient's blood glucose level after fasting for 8 hours is at the level of above 110, but should be below 126, right? But when you say impaired glucose tolerance, here the patient undergoes a 3-hour testing. The patient will be given a load of carbohydrates, it is in your book, for 3 days, and then the patient will be placed on serum and urine glucose determination. So blood and urine after that will be checked. The first specimen will be taken 30 minutes during the test. The second specimen will be taken 1 hour after. The third specimen will be taken 2 hours after. And the last specimen will be taken 3 hours later. How do we interpret this? If the person has no diabetes, the blood glucose level could already go back to normal at the end of the test. But if you have diabetes, even at the end of the test, your blood glucose level will still remain elevated, up to as high as 140 or 199, yes.
So you tested for 30 minutes, and then an hour after 30 minutes, or from the beginning?
Yes. Then after that,
2
from
hours.
1 hour,
2 hours.
the second, yeah, from the beginning of the test, the second hour. Oh, that's right. From the beginning of the test, 30 minutes. From the beginning of the test, next specimen, 1 hour, after 1 hour. From the beginning, second, so 3. So it may say that the total oral glucose tolerance test would take about 3 hours. Okay, that's the total.
So
number
they
of hours.
usually do the first one, and then if you're not passing it, they'll do the second one?
If you're not what?
If you don't pass the first one,
They will continue to monitor.
then they'll do the.
They will continue to monitor. They would even allow you to drink water sometimes, but not juices, only water to help you what? Urinate better. So your blood sample and urine sample will be, shall we say, evaluated simultaneously to rule out whether you have impaired glucose tolerance. Okay? So which one takes a long time? Impaired glucose tolerance test. Okay? So this is to determine whether the individual is considered what? Pre-diabetic. Okay? So this is not the etiology and pathophysiology of diabetes mellitus. There is problem with hyperglycemia because insulin cannot transport glucose to cells and tissues. It cannot be used as source of energy. Okay? So when the blood glucose level goes up, you will notice that if the patient will have a urinalysis test done, a patient with diabetes mellitus may have a negative what? Negative result of glucose in the urine, even if the blood glucose level is high, because the kidney's threshold for glucose is 180 milligrams per deciliter. But you would see glucose in the urine if the renal threshold is exceeded. It may say that the kidneys cannot anymore reabsorb more than 180 to put it back into the systemic circulation. So you will see glucose in the urine, right? So that is alarming because even if you have diabetes, like your blood glucose is 140 or 150, you would not see glucose in the urine because the kidneys usually reabsorbs that and put it back into the systemic circulation. Only Glucose shows in the urine when the renal threshold is what? Exceeded. And that is 180 milligrams per deciliter. Okay. So to read the glucose from the body, this is the bloodstream. Is there any question? This is hyperlipidemia. Increase what? When there is glucose in here, the osmolarity in the intravascular compartment increases. So osmolarity would mean fluid from the surrounding tissue could be drawn into the vascular bed, increasing the circulating blood volume. So if the fluid level is increased, there will also be an equivalent increase renal perfusion. So when we say perfusion, flow. Increased renal flow would mean increase in the urine output. Correct? And if the blood glucose level is so high, you could see what? Glucose in the urine. But I make myself clear that you would not see glucose in the urine if the blood glucose level is not that high. Okay? So increase urine output. So when the urine output is increased, in case of polyuria, the tendency is that the patient will feel what? Thirsty, because too much fluid has already been eliminated. So what is the tendency for the person? What will the person do? The patient is going to drink a lot of water. And what is that second P now in diabetes? The first P we said is polyphagia. I mentioned that earlier. This one, polydipsia. Okay? Increased thirst because of increased urine. Okay? So that is polydipsia. So wasting glucose, no source of energy. I told you that earlier this morning. The patient usually feel what? Shaky. So the patient will eat. That is polyphagia. So if the body cannot use glucose, now uses what? Proteins and fats. Fats here is mentioned because the one that causes diabetic ketoacidosis is the breakdown of fat into first fatty acid, then lactic acid, and what is the last phase of the breakdown? Keto acids, resulting to the development of diabetic ketoacidosis. Okay? So ketones are released. That is not polyphagia. When ketones are released in the urine, high levels of ketones in the urine, usually you could use, now I think we have the so-called dipstick for ketones, and you can also test ketones in the blood. They use a meter, which is like the glucometer. They could test for what? Ketones. Now this is very important for patients with type 1 diabetes, because I said they are the ones who are prone to what? Diabetic ketoacidosis. Because they have no insulin produced by the pancreas. Okay? So that would mean the patient maybe will develop what? Ketosis, but not polyphagia. Because that is what? Increased appetite. Okay? So what therefore are the 3 P's in diabetes? Polyphagia, polydipsia, and polyuria. Those are the 3 P's. The classic symptom in diabetes mellitus. Okay? Are we doing okay? Are we following the discussion? Okay. So that is what I'm saying, right? But who are more prone to this? Type 1. Okay? Type 2 may develop it, but usually not likely because they still have little insulin. For type 2 diabetes, I don't know if this is in your book. I think that is in your book. Yes. Okay. So what does that mean, Amanda? The acronym?
This is hyperosmolar hypoglycemia.
Hyperosmolar. hyperosmolar, hyperglycemic, non-ketotic syndrome. Okay, that is seen in people with type 2 diabetes.
Where is
Alright.
it?
I do not know what page
Like
you see that.
page 860. You know where the diagram
Oh,
is?
okay. I got
Okay.
it. Thank you.
It's almost at the end.
So this one is for type 2. Alright. Now when the acid level goes up in case of ketosis, you will notice that the patient will demonstrate the so-called Cosmos respiration. So Cosmos respiration is characterized as deep, rapid respiration. Now this could be difficult respiration. What is the purpose of this Cosmos respiration? Deep, rapid respiration, hopefully, is one of the body's mechanism to rid the body of increasing levels of carbon dioxide. Okay? To prevent an immediate development of metabolic acidosis. Okay? Now, you see, if you are good in acid-base balance, you will notice that when the body turns acid, you think of the what? The buffer systems in the body. When the body's acid level goes up, what buffer system in the body usually is acting or is coming into play to buffer? We talk about the bicarbonate, carbonic acid buffer. Remember that from acid-base balance? So release of bicarbonates in the bicarbonate carbonic acid buffer to buffer this acid environment would later lead to a depletion in bicarbonate level. So the bicarb level will be below 22 MEq, with the body pH falling below 735. Isn't it? So we have a case of metabolic acidosis. Okay, because we always look at the bicarbonate level for the metabolic problem, and we look at the PaCO2 for the respiratory problem. Okay? So, what is the one of the proposed advantages of the Cosmos respiration? To rid the body of excess what? Acid. Okay? By breathing fast. Okay? And you will notice that in ketosis, the patient will have acetone breath, or the sweetest odor in the breath. We call that the fruity odor in the breath when the acetone level goes up. Okay? So are we okay? All right. Now there are many complications associated with diabetes mellitus, and you can just take a look at this. We are going to discuss them anyway, one by one. Now, circulatory collapse is associated with severe what? Polyuria. That is why, if you will be given a question which says, what would be your initial, or which of the following listed nursing actions would you consider first if you are caring for a patient with diabetic ketoacidosis? So in diabetic ketoacidosis, we said the blood glucose level is very high, right? And the patient, because of polyuria, becomes dehydrated to the point of circulatory what? Collapse. But the cause of this is this one. So the first intervention is to administer insulin to lower the blood glucose level. And the next thing that you will do is you have to anticipate insertion of intravenous fluids in order to address the possibility of circulatory collapse. With circulatory collapse, renal shutdown could also occur. So we say shutdown when there's decreased fluid circulating in the body, flow to the kidneys decreased, the kidneys could fail. All right. Then what about this one? I told you this is associated with hyperlipidemia. Okay? And this one also, blindness and neuropathy. Actually, death is not a complication. Death is usually the bottom line, right? Yes, Dennis.
Or you said, if they're having polyuria, that you have to administer IV fluids. Which IV fluids do we?
Usually we start with isotonic solution. Okay?
Saline?
Normal saline is usually the first IV fluid that will be used. Okay? And then later we talk about, when we do the complication lecture already, we talk about replacement of electrolytes like what? Sodium and potassium, because you're losing a lot of sodium when you are having polyuria.
I asked because I was thinking if we administered dextrose, won't it elevate it more?
When the what?
If
If we
we administer
administered
dextrose.
wouldn't hyperglycemia be high?
Okay, so in patients with severe polyuria, and the patient during the case of DKA and H8NKS, when they are placed on NPO, there is no source of glucose. And they're also given what? Insulin, so we balance.
So
Okay?
you can still give the dextrose.
Yeah, but initially you could give, where is my, what is that? Alright, so initially they may give plain, but as you give, because we give you insulin, we give you insulin IV. That is regular insulin. The only insulin that is given what? Intravenously.
It's regular.
Yeah, regular insulin. That is why we check the client, we even attach the client to a cardiac monitor. But because of losses of, at the fall in the blood glucose level, we are afraid the patient will develop severe hypoglycemia. And hypoglycemia could lead to what? Coma. So we balance. We can give dextrose with IV fluid. Okay? So these are the islet cells in the pancreas. So we have, the most important are the what? The alpha and the beta cells. Alpha cells, glucagon, beta cells are what? Insulin. Okay. So,
We talked about that.
go back again here. So what are the different functions of the insulin? The different
To grow
functions of
transport,
insulin, there are three
transport.
major functions of insulin. What are those?
The transport.
It transports it's there. It transports glucose into body cells and tissues. I have mentioned that already.
The storage.
And if there is adequate insulin, glucose in excess in the bloodstream is converted into glycogen by the liver, right? And insulin also prevents the breakdown of glycogen back into glucose if it is not what? If it is not needed. Okay? So that is the most important function of insulin. And then we discussed this already, right? That is just a repetition. Okay, so that is the autoimmune, all right, cause of diabetes. And then we have type 2, that is genetic, lacking insulin. Most of them are usually what? Obese. Now this is a different presentation from what you have in your book, but they are the same. Okay, this is a summary of what we already have discussed. So lacking insulin, there is decreased glucose utilization by cells and tissues in the body. So when there is decreased utilization of glucose, what happens is that the liver converts stored glycogen into glucose, making the blood glucose more higher. So we have a case of what? Hyperglycemia. So we have the 3 P's in hyperglycemia: polyuria, that could give rise to dehydration, and then we have also what? Polydipsia. Okay? When the blood glucose is so high, this is a sign and symptom of hyperglycemia. There is no glucose available to cells and tissues. The patient will complain of weakness, the patient will complain of headache, and the patient will have what? Blurred vision. Okay? So other clinical signs and symptoms that accompanies hyperglycemia, you have there a box in your book that talks about hyper and hypoglycemia. That includes acetone breath, that is the frothy odor. Appetite is poor, patient will have nausea, vomiting, and abdominal pain. Okay? So when the ketone level or the acid level goes up, respiratory rate what? Increases, isn't it? This is what you call cosmos respiration. Deep, fast, and labored breathing to excrete excess carbon dioxide. Okay? Do we understand the picture presentation? Do not say yes if it is no. We have no problem with that? Brittany? You're okay? All right, good. So those are the classic symptoms. Why will the patient lose weight? Remember, water is how many percent in the body of the adult? 70% of the adult body is what? Weight is water. So the more you lose water through polyuria, the more you lose weight. Okay, that is why patients who are diabetics, we always tell them to drink a lot of water. Okay? And then there's also weakness because there is less available glucose for energy. Then these are the other what? Signs and symptoms. Okay? All right, so onset of ketoacidosis is what? Hours to days. You have that. Okay? And then for hypoglycemia, it is usually sudden. Now this is in what? That is in ketosis. All right, now let's talk about other things about diabetes before we go to the management. In diabetes, they believe that people who have diabetes have an altered immune function in the body. That is why you notice that people who have diabetes are prone to what? Infection. What else? The wound usually don't heal on time. Poor wound healing. Why? Glucose in the bloodstream is a very good medium for what? Bacterial growth. And people who have diabetes also have problem with women. They usually have UTI, or they could have what? Yeast infection. What causes yeast infection? A fungus. Okay? That is Candida albicans causes fungal infection. All right. Now, there are different diagnostic tests for diabetes. We have all these diagnostic tests. And people can also self-monitor the blood glucose. But before you teach a client to do self-monitoring of blood glucose using a glucometer, if you're talking about an older adult client, what first would you assess? Whether the client can see? What else? Whether the client has good coordination of the hands. Okay? So if they cannot see and they don't have a good coordination of the hands, what will happen? They will not be eligible for doing self-monitoring of blood glucose. That is why in patients with diabetes, it is important that when you plan interventions like making the patient do self-monitoring of glucose at home, we involve not only the client, but the family of the client. Because what the client cannot do, the family may be able to do. All right. So, glucose monitoring, that is, we have the many, what is this? Many instruments for glucose testing. Now, people who could not see may not be able to do it. What about people who cannot hear, but they can see? They can do it as long as they have good hand coordination, because the result is usually shown in the what? In the screen. If they have problem with, shall we say, difficulty reading, but they still are able to do it, there are now talking what? Talking machines. It says your blood glucose level is 110 milligrams per deciliter. All right, this is very friendly for the client. All right, who will need a very, shall we say, a very good schedule or rigid schedule of glucose monitoring? People with type 1 or people with type 2 diabetes? Type 1 diabetes, because they are receiving what? Insulin. They could easily get what? Hypoglycemic. Okay? So, test strip. You are doing this. Where do you check usually? The sides. Which fingers are recommended? The middle, the ring, and the small finger. So you do it on the sides because there are less
Less
nerve
pain.
supply on the sides. Let me see, how do you do it? Tell me, how do you do the finger stick?
Use alcohol pad, you wipe it once, wait for it to dry. You're supposed to massage the finger from here, right?
You massage the finger.
Yes, before you poke it. And then after the alcohol pad, you poke it on the side, and you can't remember.
You're not supposed to use the
Yeah,
first
you're
drop
not
of
supposed
blood
to
because
use,
the alcohol.
Mm-hmm.
You're not supposed to use the first drop of blood because the alcohol thins it out.
You are not supposed to use the first drop of the blood.
It says it has alcohol and it thins it out.
Okay, so you have to use the second.
Mhm.
All right. Now that is why, I don't know if it is already in the test plan for the implants. Nowadays, they would recommend that you wash the hand of the patient with soap and water, warm water, and then wipe it dry, and then do the finger stick. No more what?
No
No more
alcohol,
alcohol.
because it breaks
Yeah.
down the skin.
And they are also painful, even with injection, but I just don't believe it can be implemented. That you use soap and water for
Yeah.
injection, that is what they're saying. If you are having 10 patients for
Injection.
insulin injection, you would carry a basin every time and then clean the area with, so that is not unacceptable. But for the hand, I think it's okay, right? So warm water so that the fingers would dilate, okay? Usually we want this, but please try to find out also if the hands are already so traumatized. Because some patients, as if the fingers, the tip of the fingers are
It's all
already
burns.
so broken that they don't look nice anymore. They look bluish or blackish in color. So you have to check on that because there are alternative areas, although not recommended for patients who are using what? Insulin, like this ones. They can use it now. But I said that is not usually recommended for people on rigid glucose monitoring. Okay? So it says wipe off first drop of blood. But you see, you don't want to use that first drop of blood because it may contain alcohol. What do you use to wipe off the first drop of blood? That is another question. You will still use the same one. Alcohol preps what? Now and then we wipe it off again because it contains alcohol. Oh my goodness.
So what are you supposed to do then?
Go.
You can use anything like a gauze to wipe off the blood, okay? If that is the way we think, okay? But we usually use the first one. We don't usually use the first blood that comes out. Because according to studies, it will give you a lagging effect. So we say lagging effect, that has been there overnight. So you have to remove that and get the one that is just freshly flowing. That is also another one theory. Okay? Now we have so many diagnostic tests for diabetes. One that is usually used is a fasting blood glucose level. So the patient would fast for what? 8 hours. And not to eat anything until the specimen is drawn. But I think the current practice now is that even in the laboratories, they allow the patient to drink water, okay? And then the other one is a random blood glucose level. So say random, it is the blood specimen is drawn anytime with no regard to whether the patient has eaten or the patient has not eaten, okay? And then we have another one, a postprandial blood glucose level determination. So we say postprandial, the specimen is taken after the patient is given a high carbohydrate diet, usually 2 hours after the patient has eaten. So the patient would call the laboratory and inform the laboratory that he or she is coming, that is on the second hour after the patient has eaten. And then we also have another one that is monitoring of blood glucose level on a basis of 2 to 3 months. What is that test? It is called the glycosylated hemoglobin A1C. All right. So have you heard about that test, the A1C? All right. So A1C will give the patient or a doctor a profile of how the patient controls the blood glucose level in about 2 to 3 months. All right. The glycosylated hemoglobin is expressed in terms of percentage. Okay. What is the recommended glycosylated hemoglobin level in patients who have diabetes? Huh?
4% to 5.4.
Okay, so the book recommends below 7%. Okay, because a 7% glycosylated hemoglobin is equivalent to 150 milligrams of blood glucose. All right. Now, question. The patient has had a fasting blood glucose level done, and the result is, according to our book, it says should not be more than 126 milligrams per deciliter. Now hers is 137. The patient asks you, does this mean that I am already a diabetic? What would be your answer? The first fasting blood glucose result is not conclusive immediately of diabetes mellitus. The doctor will order another diabetic testing, like another fasting blood glucose level. This is confirmation. So if the result will remain high, it may mean some doctors usually do 3 FBS tests, and then after that, you will be diagnosed as a diabetic. So what are those tests? What is the easiest test that you will get the result? Fasting blood glucose, and that is the reliable. But to look at control for glucose, that is the A1C determination. Then some patients may have this one, but I said this takes time. We discussed this already, isn't it? The oral glucose tolerance test. It takes about what? 3 hours. Okay? And now they do the urine test, but they are not anymore doing this test, but they are usually using the so-called glucose or the finger stick result for patients who have diabetes. They could use the urine test to also to determine for what? Ketones in the blood. This is how they do the testing, the urine test. You are supposed to use a test tape or a diastix. So the first thing that we do is we have to make sure that we use the specimen that is not the first specimen in the morning, because that is already glucose that has stagnated in there. We use the second voiding. But we are not supposed to what? To discard the first specimen. Why? In case the patient could not void, we can use it anyway. Okay? Then after we did the test tape, what do we do next? Look at the color. If the test tape turned brick red, green, or yellow, we just do not guess. The container of the test tape contains color code. So you check, what does that color mean? Is it +3, +4, or +5 what? Glucose. Okay? So we know already how to do this. And for urine, I will not tell you anymore. You know already. Do not use the urine from the collection bag, right? You have to use fresh urine. Where will you get the urine sample from? You can use it. You can get a urine sample from the port of the catheter. Have you ever taken a specimen in the port of the catheter? The what? If this is the rubber part of the catheter, you will notice that there is a port in there. You don't need a needle for that. So all you have to do is let the urine drain, then plump, and then when the urine starts to drain, insert the syringe and then aspirate for the specimen in order to get the specimen. So it should be fresh, the urine that drains in the bath. Okay. So for the urine, we could check both glucose and ketones in the urine. Okay. So what is the management for people with diabetes? People with diabetes are managed in different ways. One is what? Diet.
Diet.
The other one is exercise. That is the last only is the what? The medication. Okay? So when you say diet, diet for patients with diabetes is not a diet of one for all. It is individualized. Because the computation of the client calorie requirement for the day will depend on the sex. Who do you think need more calories? Men or women? Men. What about age? Who needs more calories? Teenagers or older adults? Teenagers, definitely. The height and the weight. If you are short, your requirement also is what? Decrease. But if you're big, your requirements may increase, but it should be controlled carbohydrate diet. Remember from nutrition? Okay. And then activity level. If you are so active, your calorie requirement will be increased. Otherwise, you could develop hypoglycemia. All right. So who usually do we collaborate with when we talk about the client's diet?
Nutritionist.
The nutritionist, and we also collaborate with the primary care provider for the diet of the patient. So usually there will be an equal component of carbohydrates, fats, and proteins for a patient with what? Diabetes. And I said there is no ideal one diet for all diabetics because we have to consider all those to include what? Occupation. So if your occupation means that you are sitting all the time, you need less calories. What about if you're a nurse and you're always on your feet?
You need more
8
calories.
hours or 12 hours, you need what? More calories. Otherwise, you're going to have hypoglycemia. Right. So, state of health. If you are sick, you need more calories. Right? And we look at your former dietary habits. We look at what you usually eat because we have the so-called diabetic exchange list. So in your country, that is cultural background, if you don't eat bitter melon, there is a substitute for what? Bitter melon. Not everybody eats the same diet. So for Filipinos, if you don't want to eat curry, okay, you could have another one choice. All right. But usually we limit. We don't make patients with diabetes eat meat sparingly. Why? The number one enemy of the kidney is what? Protein. Okay? So meat usually, especially what? Red meat. Like coming from what? Beef. So if you're diabetic, you have to eat less steak. What are the other sources of protein? You have plant sources of what? Protein. And then you have fish sources of protein. There is a table in your book that talks about eating fish 3 times a week because fish will give you other benefit other than protein. It contains omega-3. But you should know the type of fish that you should be eating. What are those that contains omega-3?
Salmon.
Salmon, okay, tuna, what else? The herring, the cod, okay? You have so many, the mackerel, they also contain omega-3, okay? So many doctors believe that if you're good with manipulation of your diet, you could even lessen your need for medication, or you may not be even requiring medication. Okay? That is if you are just on the border, that is what we said. Now, talking about diet, there is what you call teaching clients about foods that they could eat when they feel what? Hungry, like hypoglycemia. So there are foods that have an equivalent calorie, like protein. So you have their list in your book. We talk about glycemic index. What is the definition of the word glycemic index?
Measure
How fast a carbohydrate-containing food can raise the blood glucose level. And the maximum, it is presented in the book, is 100. Yes. So foods that has a glycemic index of 75 and above, like what? A waffle, could bring the blood glucose level up fast. So if you intend to do strenuous exercise, you should have waffle and what? Orange juice. But if you want food that could just help sustain slowly the blood glucose level without causing a fast increase in the blood glucose level, you can use food with glycemic index of below what? 55. Okay, 55 is low glycemic index. Is it? Take a look at your book. Actually, in the influence examination, they don't give you figures. Why? Many books have different what? Presentation. So they will give you high and low glycemic index. Even with insulin, they don't specify the time. So try looking at influence books nowadays, because you cannot just be memorizing, okay, regular insulin peak is 5. They have different, presentation, okay? So, and people who are, shall we say, obese, they have to have weight reduction techniques. So if you are obese, you should know whether you're obese or not, because the doctor will teach you how to compute for your body mass index. When you say normal body mass index is about 18 to 24.5, you're good, okay? If you're above what? 30, you're already obese. If you are 40 and above, BMI, you are morbidly obese, okay? So high fiber could help decrease constipation, okay? Exercise. What is the beauty of exercise? You have so many advantages from exercise. If you're not a diabetic, exercise could help tone you down. Tones your muscle, prevents your muscle from sagging. It can also help lower cholesterol, triglycerides. It could help decrease anxiety if you are the anxious type. Displace your anxiety through exercising and you will feel what? Relaxed. Okay? And then also it helps burn calories. And exercise for diabetics help increase, what is that I have mentioned earlier? Transmembrane what?
Glucose transfer.
Glucose transporters. So therefore, what will be the... Okay, let's make this clear. Is this insulin acting on the transport of glucose across the cell membrane?
Yeah.
This is independent of insulin. It's just the transmembrane glucose transporting acting. Independent of what? Insulin. That is why your insulin, the glucose uptake is increased, your insulin requirement usually is what? Decreased. That is why when you exercise, you have to check your blood glucose before, during, and after exercise to prevent what? Hyperglycemia. But when you say exercise, what does that mean? Exercise today, no tomorrow, and again next month? What is that? Exercise means what? Regular exercise. How much exercise? At least 30 minutes per day. Who usually determines what type of exercise you can do?
Your doctor.
Consult with your physician. Do not go for high impact cardio exercises when you will just relax. Huh? You have to consult your primary physician. Okay? So those are the effects of exercise. And then when we say exercise, we do it what? Regularly, every day. Are you communicating with somebody, darling? Because I thought you're communicating with somebody to the cell phone. It says sporadic exercise. When you say sporadic, what does it mean? According to when you like it only. Okay? That causes wide fluctuation in the blood glucose level, like in the Sumoji effect. What is a Sumoji effect? Sumoji effect is what? Hypoglycemia at night, followed by, with hypoglycemia, release of epi, and what is this? And insulin. That is hypoglycemia at night, followed by what? Rebound. Rebound what? Hyperglycemia. When? During the day. Okay? So that is the Sumoji effect. hypoglycemia at night followed by rebound hyperglycemia in the morning. Okay?
So that's why it's bad, or that's why they discovered.
That is why exercise, you know, when you exercise, epinephrine is increased also when you exercise, isn't it? That is why your heart rate increases, you know, you perspire a lot. So when you exercise, do it regularly. If you don't do it regularly, it would affect your blood glucose level. You could experience swings in blood glucose level, like Somoji effect, hypo with rebound hyper. Okay? So we have what? Exercise, then we have diet, then we have insulin. What about insulin? Who are candidates for insulin?
Both type 1 and
Type 2.
Okay. Type 1 and type 2 may also use what? Insulin. Now, the very first source of insulin are pork and beef. Now, this is foreign. That is why it may cause two effects. One is what? One is allergic reaction. And second is that because they are foreign, they could be destroyed by the body's immune system. So the patient needs higher amounts of what? Insulin. And insulin for injection is expressed in terms of what? Units. Okay? So if the medication says 100 units of insulin, it means to say that 1 ml is only 100 units of insulin. So if it says 50 units, you do not give 50 ml of what? Insulin. The patient is going to die. Okay? So now we have what? Purified, more purified insulin. So how did they purify insulin? They purify insulin from what? They could purify insulin from pork. They do what? Genetic engineering, laboratory work to make the insulin like human insulin. And then they do genetic, process of making insulin through a microorganism known as Escherichia coli. Okay? So now because insulin is like human insulin, they use the word what? Humulin. Okay? So we have different types of insulin. You have there in your book. So I mentioned about the genetic engineering of what? Insulin. So that is the different insulin that we have. So how many types of insulin do we have? We also have the mixed type of insulin, right? Mixed type. You have insulin 50-30 or Novolog aspartate 40-50. We have mixed insulin. Now mixed insulin is only good for people who have difficulty what? Mixing insulin. All right. So we have rapid acting. Now by the way, these are the three properties of what? Insulin. You have the onset, the peak, and the duration. Now when you say onset, what does it mean? It refers to the time that the medication takes effect. When you say peak, that is when insulin exerts its maximum effect. When you say duration, that is the time when the insulin, those are the times when the insulin are still in effect. That is the duration. Of the three properties of insulin, which one are usually associated with development of hypoglycemic reaction? With the three properties of insulin, which ones are usually associated with hypoglycemic reaction? The onset, and again during the peak of insulin effect. So that is why we said, if you give a patient insulin, make sure, if it is rapid, especially short acting, make sure the patient gets food after administering this medication. Because hypoglycemia could occur during the onset of action. And then we give snacks to prevent what? Hypoglycemia during the peak of the insulin effect. Now, board questions are stated like, they always talk about Humulin R, Novolin R. So here, patients should eat immediately in about 5 to 15 minutes, especially these ones. You could experience hypoglycemia. That is why we check blood glucose before we give what? Insulin. But some doctors say, okay, give, because anyway the patient will eat. Now, this is the way they, what is this? They phrase the question. For patients who are receiving short-acting and rapid-acting insulin, when is the best time to give snacks? They say midday. Okay, so when you say midday, that is between 10 to 10:30 a.m. The Board of Nursing is very, shall we say, what is this? They are very, very careful with asking questions about this because not all books will have the same presentation. So midday, that is for what? For short and rapid acting insulin. What about for intermediate acting insulin? They always tell you, you could give also at around mid-morning also, 10 a.m. or 3 p.m. But for, shall we say, long-acting insulin, intermediate acting insulin, they give you mid-afternoon. So when you say mid-afternoon, what time will that be? Between 3 to 4 p.m. Okay? So for rapid and short, midday. Around noon, sometimes that is the word. But for intermediate acting insulin, you have to give them snacks. Before what? Before dinner, that's mid-afternoon, and some should be given snacks before they go to bed because of the long effect of the insulin. Now, intermediate acting insulin here, there's something missing here. Okay, the long-acting insulin. When is hypoglycemia expected here? Usually, they give you early morning for long-acting insulin. This is rapid and short-acting. This is intermediate acting, and this is what? Long-acting insulin.
So you give them snacks early in the morning?
Early morning. What is lacking here? Livermere, correct? Take a look at your notes.
Yeah.
Livermere is not there.
We have it.
Okay. So livermere, no pick, correct? All right. Where is the best site for injecting insulin? The best site for injecting insulin is the abdomen. Why the abdomen?
It has the most.
Good absorption of insulin. The best site is the what? The abdomen. Where are the other sites? The thighs, all right. The buttocks, and then the arms. Okay. So abdomen is considered the best site, except for what?
Near the belly button.
Except for
People that have just had surgery.
you have the page in your book. Except for nighttime administration. Is it there?
Oh, yeah, it says except nighttime.
Okay, except nighttime administration, and especially with what insulin?
NPH.
All right. What is NPH? Intermediate, long-acting, short-acting. What is NPH? Intermediate. All right. So except at night, so nighttime administration of what? NPH. All right. Now this is something about insulin. Blood flow influences the absorption of insulin. So if you would be asked a question like, the patient is planning to go for exercise. So for exercise, it means that the patient will be using most often the arms and the legs. So do not inject in the thigh and in the arm. Why? Exercise increases the blood flow. And I said absorption is influenced by blood flow. So if the blood flow is increased, more chances of developing what? Hypoglycemia. Okay? So you inject where? In the abdomen. So that is one thing that you also have to remember. And when you inject insulin, another board question, you should know how to rotate insulin injection. What is the reason for rotating? To prevent lipodystrophy. What is the meaning of the word lipodystrophy? Problem with fat mobilization. Isn't it? So there are two types of lipodystrophy. What are they? Lipoatrophy and lipohypertrophy. How would you differentiate the two?
Lipoatrophy is breaking down.
So you would see what? What would you see in the skin? Lipoatrophy.
No
Dimpling.
fat. Yeah.
But hypertrophy? Bumps. Okay? That is hypertrophy. Alright. So look at the picture with insulin rotation in your book. How do you rotate your insulin injection in the clinical area? You know that it's funny what you're doing in the clinical area. It's not in compliance with what the book recommends.
Yeah.
Right arm, left arm. Right thigh, left thigh. Right abdomen, lower abdomen, left lower abdomen. What is the best way to rotate insulin? You have to use all possible sites in one area before you transfer it to another area, provided there should be an adequate space, about half to 1 inch apart when you inject. So if there are 6 possible sites here, use them all before you transfer to the other side. And then the same thing here and also here. Okay? The buttocks is difficult to inject by yourself, right? How can you inject by yourself in the buttocks? Are you going to look at the mirror and then just do like that? So these are the most accessible if you're doing self-injection. So that is talking about what? Rotation. Now, if you are ordered to mix insulin, this is another board question. How do you mix? The thing is, it says clear to cloudy. Insulins usually are what? Cloudy. Lactose is clear. What is the only insulin that is clear other than lactose? Regular insulin. This is the one that is, I said, given what? IV in case of diabetic ketoacidosis. So when we say clear to cloudy, if this is the order, regular insulin, 10 units, plus NPH, 15 units. How would you do the clear to cloudy injection?
Do the regular first and then the NPH.
You draw the regular first and then the NPH? But the thing is, in the board exam, they don't ask you that. You have to inject air if you are not using the pen, correct? So inject 15 units of air into the NPH,
And
then inject 10 units of air into the regular insulin.
pull up
Then
the
do
regular.
not remove. At the same time, withdraw
Just
10 units here and
and then
withdraw
withdraw
15 units here. That is what we mean by clear to cloudy. And how do we administer insulin? Right from the refrigerator? No. Insulin should be administered at room temperature. So you have to roll the insulin in your palm to make it what?
When you draw insulin,
Yes.
this was in one of our things. It has to be long acting first and then rapid acting.
You have to follow the instruction. Clear to cloudy.
I'm just confused because
No.
one
The
of
question, you will not be confused. Because this will be usually the question even in the NCLEX. They give you an order. So if you follow clear to cloudy, you have to inject air here first. And then inject here, air. And then clear to cloudy, do not remove the syringe anymore. Withdraw one.
There's only 2 types of cloudy.
Regular insulin?
No, I'm just wondering. So it doesn't matter if it's long acting or rapid acting.
There is only one clear insulin. That is regular
Regular
insulin. Except for this one. This is also clear.
lentils.
But that is long acting. But you don't mix lactose and levemir. They're not supposed to be mixed with other insulin because they have no peak. They are peakless insulin. So they're not supposed to be mixed. And when you have mixed insulin and withdrawn them, they have to be given within what? 15 minutes. Why? After that, the insulin loses their potency, so they have to be injected. Yes, Brittany?
So you were saying regular is the only clear that you're gonna mix, even though Lantus is clear, you don't mix that one.
They are pickless insulin. They have no pick. You are not supposed to mix Livamir and Lantus with other one insulin. Okay? So the rest usually are cloudy. Have you seen the Novolog NPH? They're cloudy, turbid in color. Regular insulin, they usually are what? Clear in color. And that is the only insulin that is given what? Intravenously, the regular insulin. Now, Lantus is clear, but I will repeat, cannot be mixed with other what?
With other medications.
Other insulin because they don't have PIC. So you have Lantus and Livamir. They are both long-acting insulin. All right. So regular into the syringe first. It may say you have already injected air here. Correct? That is your confusion. Because you cannot withdraw unless you unless you instill air first. So always remember, clear to what? Clear to cloudy. So within 15 minutes, administer. This one is pickless, so we do not mix them with other insulin. Now these are examples of what? Those are examples of mixed insulin. Usually they include intermediate acting together with short acting insulin. This is for people who have difficulty what? Mixing. Okay? Regular insulin is the one that could be given IV in case of what condition? Severe hyperglycemia, as in case of DKA, and as in case of HH and KS. So we have hyperosmolar, hyperglycemic, non-ketotic syndrome. Okay? And insulin is usually given sub-Q. You are giving insulin, right? So when you say sub-Q, using the insulin syringe and needle, you administer it dark light. So when you say dark light, 90 degrees. That is good enough to reach the what? The subcutaneous tissue. But for the regular IM needle, what is the gauge in your exam that you will use?
22.
22, correct. All right. So with a gauge 22 needle, you have to administer using a 45 degrees angle. But the insulin syringe with needle that we have is good enough to reach the subcutaneous tissue. Okay? Insulin could be mixed in IV fluid and also could be mixed with what? TPN. To help prevent hyperglycemia. Can you give insulin to a patient with Addison's disease?
No.
No, definitely. All right. Because people with Addison's disease
Their insulin
They're already
have
low.
decreased production
Yeah.
of adrenal cortex hormone. Low glucocorticoid, low mineralocorticoid. Okay? So we talk about this, but what is the thing that I have made clear? Absorption of insulin is influenced by blood flow. So if the patient would exercise, avoid using the upper and the lower extremity. And the abdomen is the best site, except for what? Nighttime administration of NPH and other insulin. So you use the what? The thigh. Because anyway, when you're sleeping, you do not exercise anymore, isn't it? You don't do exercises on bed. Okay? For 5 minutes, we finish this one. We know that already.
Yeah.
So there are many ways of administering insulin. What is the most common and up to now is used? The insulin syringe.
Yeah, the typical syringe.
So it's not here, it's the next page. So insulin syringe. You have what? 100 units, and then you have 50 units. Have you seen a 100 unit insulin syringe?
Yeah.
Definitely yes. So the increment is usually 1 unit per small line. What about 50 units of insulin? This is for insulin administration, which is less than what? 1 ml. So for small dosage, we use the 50 unit insulin syringe. But do not use a tuberculin syringe for administering what? Insulin. Okay? Tuberculin is used for skin tests like the PPD. Okay? So insulin pen now is what? Insulin pen now is becoming more popular. By the way, one more question. Can you place the insulin that has already been, or that is already been used outside of the refrigerator? Insulin which are not in use should be kept in the refrigerator. But those which are in use, you could place it outside at room temperature. That's what you do. You have all the insulins there. Every time you administer what? Insulin, you don't get them, fresh from the refrigerator. And most often you take them out already, like 30 minutes or an hour before what? Administration. What is the advantage of the insulin pen? There is no mistaking when you are delivering a dose. Why? All you have to do is dial the number. Alright, the hospital will not provide insulin pen because pens are expensive than the one which is contained in the vial. Okay? So you have this 150 or 300 units of insulin. Okay? So you said you have seen an insulin pen. And an insulin syringe is frequently what used. Okay? So that is. Do you have to change the needle every time you use?
Yes.
You do have to change. Because otherwise the patient will die from what? Infection. And by the way, the needles here, after one use, they usually become dull. And the patient will complain of pain if the needle is already dull. Okay? So we go for lunch break. And you come back at 12:30. Okay, so it's 12:30. If you are not here at 12:30,